things that we can do for the people that we love so that they know that it's okay to talk about it.
So actually, go ahead and add to the conversation.
Well, what I was going to add is just to really piggyback on what you said, because you're absolutely right. The person who's feeling suicidal, the thing that they want to talk about more than anything else is suicide. And so to them, it's almost like a relief when a person notices and says something like, you know, I've noticed maybe things seem a little bit different for you. You know, is something going on? Maybe you know about some stressors in that person's life. You could say something like, sometimes when people are experiencing these kinds of problems, they might start to think about killing themselves. And saying something directly like, is that something that you've considered? You know, and kind of the training that I've had is through the Applied Suicide Intervention Skills Training, and that's one of the things that gets addressed more than anything else is getting over that hump, this idea that we can't talk about suicide because we can, and when a person's in that situation, asking about suicide is the one thing that's going to help them. People will say, well, but what if I'm wrong? What if they're not thinking about killing themselves? That, like, then what? Like, I'll be embarrassed. And it's like, what's the worst that can happen, right? The person will say, no, that hasn't, like, no, that doesn't cross my mind, you know, and it's like, and really, like, that's, but they know that you're a person that cares, and they might also know that if they ever do think about something like that, that you're a safe person to come and have that conversation with. And so it is like that stigma about asking the question, like, are you thinking about killing yourself? Are you considering suicide? Most important thing that you can do when you notice any kind of change in behavior.
That's Amy Roberts. She's with Tazwood Center for Health, and we are in a special edition of At Issue here in the WTVP studio, where we're discussing suicide and mental health for the next 2 hours. Thank you very much for joining us on the program. I'm H. Wayne Wilson, joined by an audience of more than 20 people who are experts in the area of mental health and suicide. And we welcome all of you to the program, and we welcome our audience. We are live streaming this on Facebook. We're live streaming it also on YouTube, and we'll ask you to join us with your questions and comments just momentarily. But first, I want to continue with the thoughts of Amy. Katie, you had your hand up.
Yeah, I absolutely couldn't agree more about what Amy said. Also a trainer with Applied Suicide Intervention Skills Training, and when we can ask the question, acknowledge the risk factors that people have in their lives or have revealed to us through their words or through their actions, maybe some other factors such as past history of suicide attempts. When we can say, I care about you, I'm here for you, will you let me help you? And then go on with the question about, you know, if you're having thoughts of suicide, I'm a safe person to talk to. Will you tell me about that? Are you feeling that way? And what people often feel is ambivalence. They have reasons for dying as well as reasons for living. And the more they can talk to a trusted person. I was doing a little research in preparation for tonight and saw that, you know, the vast majority of people who are falling victim to suicide are not in mental health treatment. And so what that tells me is that we need to be encouraging access to health care for all, as well as making sure that people, we can address the stigma, that we can encourage all people from all backgrounds to get the help and provide the help through clergy, through support systems, natural, informal, and formal.
And we'll talk more about providing mental health care later on in the program. Katie Jones is with the Illinois Suicide Prevention Alliance, and then Kay Blankenship with Holt Center. Did you want to add to the conversation?
Yes, I was going to talk about some things we do, and I'm also a QPR certified trainer. That's a gatekeeper training. That's for people in the community. It's for youth. It's for any group. And one of the things, the myths of suicide that we try to challenge is the fact that people are afraid to ask about it because they have this belief, if I talk about it, I'm going to make it happen. And research has actually shown that the exact opposite. It will reduce someone's anxiety, and it gives them hope. So that's part of what we do in our trainings, and at Holt Center when we do trainings with youth, we start teaching. And I find that youth are more open to talking about suicide than adults. So some of the stigma and making it more open is starting to change.
And you mentioned adults. I think in doing my research, a lot of people said, well, it's mostly a teen problem, isn't it? People in their teens, people in their 20s. It really isn't. It's more white males in their 40s is what I found. Everyone's shaking their heads. So You mentioned QPR. Dr. Boudreau, if you want to explain QPR, because you participate in that.
Yeah, I'm our suicide prevention coordinator at Student Counseling Services. So QPR is what's called a gatekeeper intervention. So it's the business of having the people who are most likely to encounter troubled students in our situation be able to intervene. And QPR stands for question, persuade, refer. There's a fourth step that actually occurs before, which is detecting that there is a person who may be suicidal. But once that's done, to be able to ask that question that everybody's been speaking of very directly and clearly, to be able to persuade them to go and get assistance or to keep themselves safe until you can help them get assistance, and then referring, ideally by walking them directly to or driving them directly to a treatment facility, but if not, at least making a referral.
But there's that hesitation. We're always afraid to, and you mentioned earlier that, oh, what if I'm wrong? What if they're not thinking about suicide? You wanted to add?
Yeah, very quickly. I just, the overall message here, and one that I hope that everybody gets that might be listening or watching this, is that just because something's uncomfortable doesn't mean it's unhelpful or that it's bad or that it should be avoided. Mental health can be very uncomfortable. We're dealing with topics we don't normally talk about. That's going to raise some discomfort. We're talking about something that makes us very vulnerable. That's going to give us discomfort. But it's the same way as I've heard comparisons of comparing mental health to medical. If you break your arm, you've got to go to the hospital and you've got to get the arm set. That's uncomfortable, but it's necessary in order for the arm to heal. If you have some issues going on mentally that are causing you difficulty, you need to seek help in order to get that help that will help you heal. So that's the comparison that I like to use.
Rob Walter is with Tazwood Center for Wellness.
And just to add on to that too, I just wanted to make the point that I think one of our misunderstandings is also that we're not experts, we're not therapists, we're not doctors. How do we address this issue? And the problem is we just need you to start that conversation. We need you to sound the alarm. There are plenty of resources out there. I'm sure you're going to post some resource numbers, and certainly we have those in our community as well. So you don't have to be an expert, you don't have to be a therapist. You just have to know how to contact those resources and help support that individual through that journey.
And to do that, we have on the WTVP website, that's www.wtvp.org, we have some of those websites that you can go to access information both locally and nationally, and we'll be giving you a phone number, which is the suicide helpline that will be given several times during this program. I saw a hand, Dr. Sierra.
Thank you for having me on the panel, and I am just really thrilled to hear some of the comments that everybody's are sharing. And I think for me, I use a term quite commonly, which is normalizing. You know, and one of the things that I like to do when I talk to someone, whether it is a child, which it's my area of expertise, or I even see an adult, is normalizing mental illness, which I think is our job as providers. And I think everybody who works directly or indirectly with patients with mental illness, which is okay to feel anxious. It is okay to feel sad. And then when we put that taboo and that stigma applied to that is when things escalate to the point of possible suicide completion. You know, so I think that you don't have to be an expert. You don't have to be a therapist. You don't have to be a child psychiatrist or even an adult psychiatrist to know that depression, anxiety, and mental illness can kill people from suicide. And it is just a matter of have that awareness, to have that curiosity of noticing changes in patterns of behaviors, to say something's not right. Right? Maybe you are that person, whether it is a friend, whether it's a family member, who can identify something's not right and we need to intervene. So I think that just normalizing what mental illness is, it's the first step to recognizing some of those people that will come undiagnosed and fail to have that support provided for them.
Dr. Sierra is a doctor of psychiatry with a specialty in adolescent behavioral health at Unity Point Health Methodist. Thank you for joining us this evening. Yes?
I love that we're talking about normalization because I think that that's just absolutely crucial. Because we know that the biggest reason why young people especially, but everybody doesn't ask for help is because of that stigma. So I lead Ending the Silence, which is McLean County's suicide prevention program. It's a Project Oz and National Alliance on Mental Illness collaboration. And in addition to sharing resources and warning signs, when we visit these kids, which are 6th graders and 9th graders who are just starting middle school and high school, I also share my story of recovery because I attempted suicide as a teen, and now my life is really good. And I think it's so important that we show kids that even if life is hard now, it can still be good later, and to give them hope and role models, and to show that normal people struggle with this, and that it is totally okay if at some point they need extra help.
Thank you, Colleen. Deborah.
I work with children and teens. My specialty is with children and teens on a private practice. And a lot of the times I'm always trying to think of, there is the negative, of course, with the whole idea of suicide, and especially the person who's feeling that way, but trying to move it into problem solution. So if you're a family member and someone's telling you, and you're talking and they seem very depressed and they do say, I want to kill myself, I mean, if they're very serious about it, of course, you've got to get them into the ER, call the doctor, get 911. But if they're saying, I'm thinking, I feel that way, but I don't really want to die, but they're very, very depressed, to start that conversation of what do you need to change? Like, what has to be right for you to feel like, okay, I can handle life? Because then the next thing would be, well, what if we get the help for you? Or what if we make these changes so that these things could actually happen? Now, most of the time they'll say, well, it'll never happen. But at least that starts some hope forward. And that's one of the things, if I do have a family member or a child that starts to say to me that they're thinking about, that they would just like to be dead, or they want to go to sleep and they don't want to wake up, I hear that a lot. So I immediately ask them, well, would you like to die? Do you want to die? And if they say yes, I said, well, do you have any plans? And I check right away if they have a definite way. The majority of them say no. But I say, okay, what needs to be different? And then they begin to tell me about the bullying at school or something going on in their house. And then I actively, in that time, see if there's something I can make a change in that very session so that they can begin to feel, okay, things are going to get better, and to give them that hope.
Let me go back to Colleen, and we'll get to the rest of you, an active audience this evening. But she referenced, attempted suicide. You attempted suicide as a teenager. Did someone try to intervene? Were you thinking about this for a long time? What were the circumstances?
I started struggling with depression when I was 10 years old, and my parents had no idea what was happening. They thought that being a teenager was supposed to be hard and that I would grow out of it. And because nobody knew how to identify the warning signs, I struggled alone for many years. And although I eventually got into treatment, it took way longer than it should have because nobody in my life knew that I needed help. And also because I was afraid to say anything. I thought that if I told people what I was thinking and what I had done, that they would think that I was a freak or crazy and wouldn't want to be my friend anymore. So basically, I just tried to handle it all on my own, which is why now it brings me so much joy to be able to tell kids that they don't have to do it on their own, and that it gets so much easier when you have people on your team who can support you and help you get through those hard times.
Tasha, Tasha Mox is with the Livingston McLean chapter of the National Alliance on Mental Illness.
Yes, I run the suicide prevention program with Colleen over there, and I was going to piggyback on what she was saying about the warning signs that your kids were showing. We teach with the kids how that gut instinct that you're talking about, that gut instinct that they showed. I also had a suicide attempt back about 10 years ago. My husband had seen those warning signs that you had talked about, and because of those warning signs that my husband had seen within me, that's why I'm still alive. He had seen warning signs within me that I had given, things that I had spoken about in my life. And because of those warning signs that he had seen, I'm still here because I had taken my son in bed with me and said I was saying goodbye to him. And so he called 911, and I was able to be alive still. And I'm lucky that he had seen all those warning signs. So we teach the kids during that program warning signs that they can recognize within their friends. So we don't just give them tools, we're teaching them a whole list of tools during that program.
Your husband is here, and I know he hadn't planned on speaking, but could you share with us, she said you saw warning signs, and Tasha, stay standing with him.
Yes, she basically, I knew she had been kind of depressed you know, a few days prior, more so than usual. And basically how it happened was I walked into the room and saw her with our son in bed with her, just kind of, you know, hugging on him and stuff like that. And she said something very odd to me, that she was saying her goodbyes to him, and that struck me as funny. So I immediately called 911 at the time. Was there a sign before this that something was amiss? I mean, she had been depressed before that, and ultimately got diagnosed as a bipolar, and some other things as well. But there were warning signs as far as the depression and things like that. Yes. And Tasha, that is all under control now?
Yes, I'm stable now.
Thank you.
Thank you.
Dr. Sierra, did I see?
One of the things that I'm hearing, I think, commonalities from everybody is that not only warning signs, but that we have risk factors, right? And sometimes, especially, I mean, even in children, from the time that they're little, we know that they come to school and hopefully they have intact families, which is not always the case, so that we can identify those children that comes from broken families, right? And mental illness starts when you're young, right? And unless there's any intervention, it progresses to adulthood, and suicide, it's a reality at any age. At any age, not only children, adolescents, adults, the elderly. So what I am sharing with you today is that there are some risk factors that are very real, right? Broken families, abuse, substance abuse, right? Big risk factors that can precipitate depression and ultimate suicide.
Let's talk about some of those risk factors. I'll throw out some of them, and if some of you can respond to them. There's a couple of different categories. One is genetic. There's a genetic risk factor, and everyone's shaking their head. Would you like to address that particular issue? Cindy Artis Jenkins.
We learned after we lost Tim that we have a pretty significant family history of mental health and issues, and that would have been helpful information. But I think, you know, some of that went back to, you know, siblings of my grandparents, and that, and back then the stigma, you know, it was really a stigma, and so that definitely wasn't talked about then. And so I think if the family history piece is really important for everyone to be aware of, and not be afraid to talk, just even amongst your family, even if no one at the time might be exhibiting any symptoms or signs, you know, just so everyone knows.
But this was information you found out after the fact.
Yes.
As a matter of fact, let's stay with the topic so that our viewing audience understands. Tim, your brother, one of 9 siblings, died by suicide in 2002. Can you explain what happened with Tim?
Yes, Tim was, and I always tell people, you know, suicide knows no stranger, and I think a lot of people have an image, you know, in their head of someone who is on the verge of committing suicide. Well, that was not Tim. He was a outstanding athlete. He was an academic All-American in college, you know, in football, and he was a popular friend and an uncanny success at absolutely everything he did. And he just, and I wouldn't say he was depressed. I noticed he had gotten a little thin. You know, he was never a big guy, but he had gotten thinner than normal, and he looked really tired. And I asked him about it and talked to him about it. And you know, it was stress of the job, and he was in sales, and so he was always, you know, always hitting his sales goals, but you know, exceeding them, because that was just him. But every time, I mean, he was okay, and I asked him every time. So, you know, I wouldn't say he was depressed. He just wasn't himself. But I did ask him about it, and I know my older brother, talked to him about, things that were going on. So, I think one of the important things to know and for people to be aware of is the classic symptoms and signs that we always say, what's right. What happened to Tim isn't necessarily what would happen to Katie or what I would experience. Everybody's different. It's just that what's out of the normal for that person.
Amy?
Yeah, so just to piggyback off what you're saying is that that's really true. It's the abnormal behavior for the individual. And even something that I think a lot of people don't realize is that sometimes a person will actually appear as though they're better before they will take some action to end their life, because they will be maybe in that state of ambivalence about trying to decide, going back and forth about maybe I should kill myself, maybe I shouldn't kill myself, maybe I have reasons to stay alive. But the reality is that when a person makes that decision, they're no longer in that place of ambivalence. They might actually all of a sudden seem very much better than they had been in like the previous couple of weeks. And so that's actually can be another good time to ask somebody about suicide, is if all of a sudden their stressors, the problems they've been facing don't seem to be a problem anymore.
If I can go back to you, Cindy, what did Tim say because you asked him, you noticed some things, what did he say to you?
He said, that it was always, he'd been traveling a lot for work and had had a lot of presentations. It was just the stress, and, they had a new baby, and, so it was all those things, but that, he was okay. And he would come into town and, Caterpillar was one of his accounts, and every time he came in, we had lunch, we got together, and, those were, I think, some of the reasons why I noticed, him looking so different. He looked tired, and of course you'd think baby, and, that makes sense, and, the job. But, we did, ask him about those things.
Deborah, you wanted to add?
One of the things I really want families to know that are listening is to not assume that you should have known. I mean, of course, we're going to give you all these risk factors to watch for, and definitely watch those with your family. But at the same time, I mean, and I think this is really clear, and it's always helped me in my practice. I used to work at Illinois State Psychiatric Institute. Actually, I did my internship there on the experimental ward. So we had a lot of head doctors there that all studied, psychiatric illnesses. And we were around a table of 10 of us with doctors out of Yale and Cambridge and Harvard and all these social workers and psychologists. And we got together to assess if a patient could go home that weekend if he was safe enough. And he did go home, and he did kill himself. But I always think of that, because I think if 10 people who study this and give their lives to this, and they didn't know, how can you expect, when you put that guilt on yourself, for you to have caught it? And along with that line, I wanted to jump off something you said, that how people act better. The highest point of high risk for suicide is actually that week home from the hospital. So they've been hospitalized and they seem better, and everyone in the family kind of lowers those precautions. But that's the week when they really have to be seen, counselors, and being taken care of and watched, because that's the week when they're really at risk. Coming back into the world and seeing that things are still the same. Yeah.
Katie Jones?
Yeah. One of the founders of the Illinois Suicide Prevention Alliance lost her son, who was a Bradley student, in the week post-discharge from the hospital. I'm really glad you made that point, because this is one of the foremost quality issues when we look at healthcare and mental health in particular. We're talking a lot about the risk factors, but the solutions are there, getting treatment. We have wonderful, talented healthcare providers in this room, in our community. More and more people have access to care, but what's critical is that we make sure that we're delivering quality care. And one of those ways that we measure that now is ensuring that a person has a follow-up after hospitalization appointment with a mental health provider within 7 days of hospital discharge, precisely for that risk factor. But also because, when I ask a group of people at a recovery conference, why is that important? People who are in recovery, such as some of you who are here tonight, they say, because my medications might not be working, or maybe I didn't have the money to pay for my refill, or maybe I missed my follow-up appointment the next day with my caseworker, and so I'm homeless now. So all of these things require that a follow-up appointment after hospitalization is absolutely critical. I just want to say, too, that we have to be thinking about health disparities. You mentioned particularly like race or age that could be risk factors. And maybe this is on your list, but I think it's very important that we note that LGBT youth are 6 times more likely to die by suicide than their similarly aged peers. In our schools, we have a wonderful support system within our special services, making sure that youth from all backgrounds are feeling supported. So I just want to give notice of that. I have kids in District 150, and they've been really provided the support that they need around those issues.
And there's a helpline for those individuals, those young individuals, and the Trevor hotline, and we'll give that number as well as the national number in just a moment. And we'll get to your responses here in just a moment. But first, we have a question from Kayla, and we are taking questions on social media. You can go to hashtag WTVPAI if you'd like to participate. Kayla says, I work in healthcare and attend a local nursing school. Unfortunately, I have seen many situations where healthcare professionals are degrading or making fun of those who present with mental illness. How can we change this in healthcare? What are the next steps to reduce this stigma? And who would like to tackle that question? Mike Kennedy has a big grin on his face but does not want to talk. Mike is the president and CEO of the Human Service Center in Peoria.
I want to go back to a comment Dr. Sierra made, and it was the best one you can make about normalizing this whole thing. And what I think of is we've talked a lot about how we put our eyes on other people to see if they're presenting symptoms that they may be suicidal. And what I think we're seeing more and more of an effort about is teaching, we look at ourselves. You say to a child, you say to whoever, I looked around this room and thought, I'm probably the only one this is going to apply to. I get a magazine called AARP. And within it, they do a lot of things where they say, are you experiencing this? Are you experiencing that? And it may be a healthcare issue. When you started the program off with where some of the highest rates are, which is men as they get older, it's one where I really like that you do a self-examination and normalize it to say, stuff's happening in my life and maybe I need to talk to somebody about it.
Dr. Sierra?
This is a big question. This is a big question, but I think that there is one specific answer for that question, which I think it's very key, which is education, right? Educating not only providers in the mental health field, pediatricians, internists, specialists. I think we're all responsible, right? You will have someone in front of you going through a surgery, having treatment for diabetes, having treatment for hypertension, having treatment for a lot of medical problems. You may have contact with nurses before you enter and go and see a physician for a medical problem. So there are so many people out there that can ask that questions at so many stages in the life of a person, right? Recently, Unity Point had a talk for pediatricians and geared toward primary care providers in the community for treatment of this seriously ill child. And I was flattered to be invited for that conversation because the seriously ill is not only the child that is septic in a hospital in ICU bed, or a child that had a concussion and cannot play sports. It's also the child who suffers from depression, from rejection from the parents. So I think that normalizing and recognizing that we are all responsible for asking this question at some point in your life, at some point in the treatment of a medical illness, or at any point in time you're in your educational career.
Dr. Sierra's specialty happens to be in adolescent behavioral health. So I want to stay on the adolescent issue. Derek Booth is here, and he's with Peoria Public Schools, and you deal with emotional training and dealing with emotions of young people.
Yeah, and I think one of the key words I agree with is definitely that not only educating, but that normalizing for our not only our students, but our staff. to make it comfortable. Students and families don't want to be stigmatized, but when we're intentional about bringing in speakers or having our experts that we have in the district, counselors, social workers, and psychs, we also work with many of the experts in the audience today from Holt, and to come in and have conversations on suicide prevention, to share with them who you can go to, what do you do when you're having different signs or symptoms or thoughts. So I think that's a big piece, and making them aware that they're not in this alone and they're not the only one dealing with it. It's also critical that we train staff. You know, teachers were trained to teach math, English, science, and social studies. But teachers and educational staff have to be trained on when they notice differences in students to seek out for help. And we train staff on resources they can call right here in the community, of whether it's our partnerships with the Children's Home or Holt or the 1-800 lines. So when they don't know what to do, we give them steps and resources to do. But it's in the process of educating everyone, the students, the staff, and even the parents with this issue.
What's the practical process that you go through? You train the teachers and staff? What happens when they see something in a student? They see them every day. How's that work?
Yeah, this is the second year of the Office of Social Emotional Learning, and one of the things we understand that we have to do is train educators to have that, what we call a trauma-informed lens. You know, again, someone putting their head on their desk may not be just to be rebellious. It may not be just they don't want to learn, but to try to have that trauma-informed lens. What's going on with this student when they're showing us signs? And so that's part of the training that's kind of taking place throughout Peoria Public Schools now, is that having that trauma-informed lens. And then how do we help the student seek assistance?
Does the teacher call somebody, or they don't approach the student, do they? Or do
if
they?
They're comfortable. Again, I think it's important that we try to empower teachers not to be scared of certain conversations, not to be afraid of those conversations. The teachers are the ones that are on the front lines of building those relationships. So sometimes it's those relationships and their questions and their asking, is something wrong, what's going on, can be the difference. But then there's other staff and supports that they can pass the student along to get the supports that they need. But we definitely want teachers to not be afraid to have those conversations, like someone mentioned earlier. You know, just asking that question, and don't just brush it off. And it's always better to err on the side of caution than not to address the issue at all.
Faye Freeman Smith is here from Heartland Community College.
Yes, and I agree with Derek and other members of the audience. At Heartland, the counseling services there reach out, go to the classrooms and educate and do different programs. At the beginning of the year, we have training for staff, and part of the training is helping distressed students. Did you know that 70% of the freshmen that come to college are anxious? 70%. And there's a lot going on in the world today, and our youth are anxious, and they come to us like that. And so it's very important to have that outreach, not to just sit in our counseling offices and wait for them to come to us. So we do things at Heartland to go to the students. And we do have a Nomni club on campus, and they do different things as well to normalize the talking about mental illness and suicide on campus. And then supplying those programming ideas, as well as having the staff, the clinical staff, there to help the students through issues.
Let me follow up on Faye's comment about anxiety, because anxiety actually is a form of mental illness. And I don't think we always look at it that way. I'm just anxious today. I've got a big test coming up, or the boss is reviewing my past year's work or whatever. A UCLA study of freshmen, they've been doing this since 1985, they ask students, freshman students at UCLA, do you feel overwhelmed by all that you do? In 1985, 18% responded in the affirmative. Yes, I feel overwhelmed, 18%. By 2016, last year, 41% responded, yes, I'm feeling overwhelmed by what I have to do. Are we just recognizing this more readily now, or is there a lot more anxiety in our society? Faye, go ahead, continue.
Well, I think part of it is that we are addressing the stigma issue, and that more students are coming to counseling services. So that's one of the things. The other thing is that it's more students being anxious. There's a lot of different things. The social media, they disconnect personally, and when you don't have that connection personally, it causes some stress and anxiety. The burden of financial aid with students in the colleges is a big stressor when they come. So when you talk to a student about anxiety and you help them understand that this is probably what goes on with most freshmen who come to college, you can see a relief come over their face, and then you talk about it. So.
Camille Springer is also with Heartland Community College.
Well, I was going to say, when I work with students, so often one of the first things I say is, I bet you're an overthinker. And they look at me like, wow, you're really good. But really what it is they're overthinking everything. Mm-hmm. And, you know, what we do a lot in Heartland is helping them be in the moment, helping them to learn to be mindful. That helps with some of the anxiety. That helps with some of the depression. But that's a lot of things that they're just constantly thinking and constantly just going from 0 to 100 in about 30 seconds of where their life is. So,
Derek Booth, and then we'll go to Deborah Simonis.
Yeah, one of the biggest eye-openers last year, in the first year of the Office of Social Motion for Peoria Public Schools, we use a lot of data in this educational system, but typically that data is around grades, discipline referrals, and attendance. And so when we make decisions on where to place therapists as far as our high-need students, those are the data points that we kind of utilize, who's having the most issues. But one of the biggest eye-openers is in our gifted programs. Some of our gifted programs, those students don't show up in the data. They have the best grades in the district. They don't miss school. They're not discipline issues. But they are suffering from anxiety for whatever reason, whether it's getting a B on a test. And so we kind of had to go back and understand the need, and that also started that conversation of having that trauma-informed lens. We have to learn to look beyond the data because those students will never show up on the data, but they're suffering from that anxiety and need those supports as well.
And I'm glad you mentioned that, because, and we'll get to Deborah in just a moment, but there was an article in the New York Times Magazine just this month talking about anxiety and how a student from North Carolina had gone to North Carolina University, if I recall correctly, and was a top-notch student. Was an overachiever, in senior year, was taking 3 advanced placement courses, and then got to the university and the wheels started to come off the automobile, and nobody saw it coming. He was really good at everything he did. He was an overachiever, and sometimes we see that happen, and, well, I didn't see that coming. Deborah, please.
I really like how he said having the traumatized lens, and kind of along with that anxiety. With the traumatized lens, you're looking at and seeing, you know, these people have had trauma. Well, why are we having so much trauma? And when I kind of kept thinking about coming here tonight, I was like, well, what's causing all of this? And I started to think it's basic attachment, that we're not having that attachment in the family like we did in, quote, the good old days. That kids aren't having the memories like I know I had, where you just didn't have anything to do and you hang out with mom and dad. You went and played in the woods, and when school was out, school was out. I didn't see some of my friends. I saw maybe 2 friends the entire summer. Now school follows them. It's in their back pocket on the phone. They come home, they're doing homework, they're on their phone. My daughter had her friends over, and the 6 of them that are in the room, however many, all of them are every now and then saying something, but they're on their phone. So now this conversation is no longer just between us, it's between us and every one of those people that's talking to us, and every one of those people that they're talking, and on and on and on. So that creates anxiety. Pressure. I'm not just thinking about this soul time, or even this is very comforting in a sense, because it's just a few of us here talking, and nobody here is on your phone, you know, and that's really nice. I know that we're hearing each other, but that doesn't happen much now. And so when we're thinking about suicide, I think we need to go back to the origins of why is it increasing, what's going on, what are we not doing that we used to do? Are we playing game nights with our kids? Are we eating dinner with them? Are we all turning our phones off? Are we making family attachment connections? And for all of the parents to look at that.
And we've got many more people, and we'll get to Samuel Sears in just a moment, but I want to remind you all that there was a professor at the University of Toronto years ago. He coined a phrase called all-at-onceness. Back then, it was reading the newspaper, watching the news on television, chatting with your spouse, making sure the kids got their homework done. That was all-at-onceness. That has been multiplied tenfold with social media. So to your point, there is an awful lot of interference, if I may call that, too many things happening all at once. Marshall McLuhan called it all-at-onceness. Samuel Sears.
So on the topic of anxiety, anxiety itself is a risk factor for suicide. And the reality is, I frequently see consults at the hospital as part of my clinical part of my job. In what I do, I see the aftermath of attempts that didn't go through. And what I often see is a great deal of desperation, a great deal of a sense of isolation, that no one really is connected to them, at least from their perspective. And so when I'm hearing these topics about social isolation and media, it's not a surprise that this is increasing in severity. You can't make an empathic connection to somebody in 180 characters. You can't Snapchat feelings and emotions to people. And so the reality is we have to find a better way to get people connected back with people. You need friends that you can talk to and support you, not just 180 characters of what are you doing right now or a picture of what meal you're having. These are the things that help us be protected, help us connect, help us recognize when something's wrong, and be there for each other.
Samuel Sears is the medical director of behavioral health at OSF Healthcare. Right here, Dr. Boudreau.
I just wanted to note some things that folks have been talking about, which is the prevalence of anxiety. Anxiety has surpassed depression at our counseling center as the main reason people came in. It has surpassed depression in most counseling centers around the country at this point. And some things I think about in terms of anxiety is at once increasing tuition costs, so the need to work more, the need to take more classes to try and get in on time. Maybe there's also been a family job loss or transition also as a result of the economy. So people are dealing with that. In terms of social media, there often is a sense of this tremendous imaginary audience, and that people put forth kind of a much more positive, favorable image than what's really going on. So there's this sense of needing to keep up appearances for now hundreds of people instead of dozens of people. And I think that also is fomenting a lot of anxiety when people don't quite feel they match up to their electronic presence.
If you'd like to add to the conversation or have a question, please join us on social media at hashtag WTVPAI, Dr. Sierra. And I guess that we shouldn't have given that out because now everybody out there is anxious. Dr. Sierra.
I just wanted to support his comment about really the most prevalent form of mental illness is anxiety. What happens is that it comes in comorbidities with other disorders, right? So they don't often happen in isolation. You can have a combination of depression with anxiety, bipolar depression with anxiety, schizophrenia with anxiety, and the risk of suicide applies equally to all of them, right? In one form or another. And I think that anxiety, it's one of those things that comes in lots of colors and flavors, right? That anxiety doesn't necessarily come from worrying for no particular reason about things in general, but comes from those vulnerabilities that you may have, right? You can be bullied at school, right? Causes a great degree of anxiety, school avoidance, academic decline, and that can continue throughout a lifetime. You can have home environment stressors that can contribute to a lot of anxiety and may project in other areas, substance abuse. So there's a lot of things that can be risk factors from the time that you're little all the way to adulthood. And in children, in the school and universities is those big transitions, right? When you are in elementary school, you have one teacher and you're very supportive and parents are very involved. And as we foster that independence, as we move into middle school, high school, and college, then those transitions are big vulnerabilities and risk factors for children and adolescents and even adults.
And Kay Blankenship, you earlier wanted to add to the conversation. Kay is with the Holt Center for Healthy Living.
I can talk a little bit about going to we live in a global world. I joke when I talk to kids or clients, and I say, when I was a kid, we had 2 TV stations. You got the news at 5, maybe at 10, and if you didn't, you waited till the morning to read the paper. Well, think of the world we live in. We have nonstop cable news, right? 24 hours. Right. Also, the thing with kids, they are identifying with the media and their media devices. It's a part of them. They've done some studies where they've done helplines and also medical helplines, where on those crisis lines that people are texting, and it's young adults and kids, they go during a text and say, can we switch to a phone? I want to talk to you. They will disconnect. So they also did another study where they had young adults and adolescents do an activity and process. They would not let them answer their phone. It raised their blood pressure, it raised their anxiety level, and it messed with their concentration. They did this study again with these kids and young adults and let them interrupt to check on the phone to see what was going on and go back to the task. They could complete the task, and then their blood pressure remained lower. So it's part of evolving, and I think as parents, family, community people, it's there, and we have to deal with it. So it's something I think the more we know about and understanding, we'll do better.
Deborah and then Katie.
We lost our cousin's 14-year-old son this August to internet phone bullying. Well, actually, it was on the telephone with him with texting. He's a 14-year-old kid going first year to high school, smaller than his peers, had a group of kids he was wanting to hang out with. And one of the boys did what's called catfishing. And catfishing is when you pretend that you're somebody else and you try to fool that person. So he posed as a girl wanting to date him.
On the internet?
On the phone.
On the phone?
And kid fell, our cousin's child fell for it, and he got very involved with this and was going back and forth until it was, ha, 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 I'm actually so-and-so at school. I'm going to tell all the guys, and I'm going to show everybody this. His mother found out, and it's hard to even talk about because it's terrible. His mother found out and talked with him a little bit and said, Lucan, go in your bedroom. I want you to think about this a little bit. Sent the younger sister in to get him when it was time to do something, and he was hanging from his bunk bed. But I mean, this is a kid who, there's no reason that should have happened. And actually, I think parents need to know, and everyone needs to know that the federal government's taking this so serious now. Up in Michigan, what happened was they found out that the child that had done this to Lucan had the week prior told a girl through the internet to kill herself. And luckily, she didn't. But that child's actually being prosecuted now when I last heard about it.
Katie.
Yeah, so several of the comments have revolved around the programs to solve the challenges that we're discussing, and the QPR, assist, also just some of the kind of common sense tactics that we take in terms of normalizing these challenges. I really feel compelled to talk about a program that's been working in our area and in our state. It's very robust, particularly in this community, thanks to Mike Kennedy and the Human Service Center and the work of the recovery services. But it's called WRAP, Wellness Recovery Action Planning. And it's where people can identify, Taz, I know too, people can identify what are my stress triggers, what things remind me of that trauma, and what can I do as a response? How can I proactively plan? So it's really a disease management tactic. Evidence shows that it's effective in not only reducing the symptoms of depression and the alienation, but in improving the support. What I really like about WRAP, when I first learned it, I was pregnant with my first child, and as a young person had some depression, so I wanted to be very proactive and make sure that I was connected to all of my healthcare providers and support systems. And so I had a WRAP plan, and after I had my first child, I had some symptoms that looked like depression, but I was very happy. I loved my job. I was happier than I'd ever been. I had this new baby. I ended up having a thyroid condition, which I discovered when I went to my healthcare provider because I had a WRAP plan, because as a healthcare provider, I was encouraged to know thyself, So I think all of us bear the responsibility to talk about it with our neighbors and our friends, to normalize it, to know what we can do to take care of one another, and then to share that with our support persons. When we go through ups and downs in life, I also feel it's very important that we talk about senior citizens, because though Caucasian men in their 40s are at very high risk, we also see senior citizen white men also at very high risk, but senior citizens in general often undetected. In fact, the vast majority of people who have died by suicide, according to a JAMA article, was that the majority had seen a physician in the months prior to their suicide. They're seeing the nurse, the doctor, but they're not disclosing, they're not being asked, it's not an integrated healthcare solution. So we've got to make sure that the social workers and counselors are working in tandem with the physicians. Our health systems in this community are doing a great job of that. And WRAP is Wellness Recovery Action Plan.
We have a comment from hashtag WTVPAI. I will totally agree with the social media. I either feel completely connected or detached due to my phone. Either completely connected or totally detached due to my phone.
I just wanted to add on to her comment, too, about asking those questions. I'm the Director of Behavioral Health for OSF, and I know we're not alone in this, but now when you come into the emergency room, when you're in our inpatient units, when you're getting an outpatient test, we're starting to ask about these suicide questions, because we know that not everybody will share that information, but most of the time when you ask, they're honest. So we've got to keep asking. And that was a very uncomfortable thing for our nurses to do, too, is to ask those questions when they don't feel like that perhaps they're the experts. But again, we give them the resources to reach out to help assist those patients as well. So it's important, again, it's another question in your normalization realm, too, that we discussed, too. You know, we look at your blood pressure, we look at your medical history. This is part of that medical history, is that mental and emotional piece as well, and we can't leave that piece out of the equation.
We've been talking about communication and how do you address somebody when you notice a change in their activities or their behavior. And then there's the communication that the coroner has to deliver when he has found someone who has died by suicide and has to notify the next of kin. Jamie Harwood is here. He's the Peoria County coroner. Is there a protocol for your office in terms of if it's an accident, you handle it one way, if it's a suicide, you handle it a different way?
In order to stay unbiased, we tend to handle all of our deaths, approach, and investigations in the same manner, quite frankly. However, when we know someone has taken their life by suicide and we have to go make that notification to the family, it's a game changer. It's hard, first of all. It's not something I would wish upon anybody to want to do. The approach has got to be a little bit more soft, if you will, as opposed to matter-of-factly. It's very difficult to let a family know that not only has their loved one died, but their life is gone by suicide. And I've sat with several families and had to make that notification and have those conversations, and they're very difficult. They're tearful, and every family that I've had a conversation with, they're dumbfounded. They had no idea that their loved one was going through a depression or an anxiety issue, and they struggle even to accept the fact that it happened, to be honest. So in that case, we have to provide structural evidence to support what we're telling them, to give them some realism to what they're talking about.
Do you offer professional help so they can connect with a therapist or a clinical worker of some kind?
We do. We do our very best to provide resources after the fact. We're a huge supporter of the Bow Grant Foundation for survivors of suicide. There's a timing issue with that when you broach that subject with someone. Here your loved ones died from suicide and now you need to get help for support. There's a timing issue with that, and so you kind of get a feel for where are they at in that moment, and sometimes it's a delayed response.
Tasha Mox?
I was going to say, we were speaking a lot about phones and how they're given a bad rap on how they are discouraging with the youth. I was going to express how my son actually expressed his depression through the phone. My son was able to tell me about his depression through the phone, because a lot of times youth are not able to tell us that they have depression face-to-face, and a lot of times they're able to tell us things that they wouldn't otherwise tell us face to face. So they will tell us things by text. I cut hair, and I was able to tell my son, you know, you don't have to tell me that you need help, because if you need help, all you have to say is that you need to talk to someone. So he wasn't going to tell me face to face, but he was able to tell me by text. So we give texting a bad rep, but because youth are so comfortable by text, they'll tell parents things by text. So we give it a bad rep, but text is a good way for them to communicate with us as parents.
Camille Springer. I'm sorry. I'm sorry. I'm looking for hands, and I thought I saw your hand. Sorry.
I think that that's an excellent point, that technology can really be such a double-edged sword, that when we're talking about social media, especially with young people, it factors so strongly into the problem of bullying. But at the same time, it can be a great resource. And I think, especially for young people, the crisis text line, which is 741-741, is an outstanding way for them to reach out. When we do our presentations, we have a spot on our evaluation where they can mark if they need help, because sometimes they might not feel comfortable saying it out loud, but if they write it down, then they can start getting care, because it is hard to say it out loud. So anything we can do to make it easier for people to reach out, I think is something we should take advantage of.
And I apologize, I saw a hand go up out of the corner of my eye. That's Colleen O'Connor, so not Camille. You wanted to add? This is Cindy Artis Jenkins, and for those of you just joining us, Cindy's brother died by suicide in 2002.
Yes. So we're talking a lot about communication, and you know, Derek, you mentioned training teachers and that, and I think it's really important that we're also opening and normalizing the conversation with our youth. And you know, it's one of the things that you know my family has tried to do is helping to educate youth. And there's a teacher at Richwoods who asks me to come and talk to his psychology class every year. And I think that's been, and he tells me it's been, you know, really helpful, but that's letting kids know that they play a role too in understanding their friends and understanding themselves, and that it might be a difficult conversation, but there are always people who are there for them. If hopefully it's a family member, but if it's not, it could be a teacher, it could be a bus driver, but that you know, they may recognize something in a friend, and it's important that they take, you know, that seriously and let, you know, the friend know, hey, I noticed, you know, you haven't been going out with us as much as you normally do, but just opening that conversation with each other, too.
Oh, also from hashtag WTVPAI, we have a message from Jerry. He wants to know if there's a difference in suicide occurrence, rural versus urban. Is there somebody who can address that issue? I did not come across that statistic. The Holt Center, yes.
One of the
this is Kay Blankenship.
You see, excuse me. You see, if you look at rural and urban, depending on where you're at, you're going to see a higher rate for rural. And also, if you look at socioeconomic status, if you have a rural or urban area that has at a poverty level, that also is going to increase some of that. And if you look at from out west, if you look at some of the states like Wyoming, Colorado, Montana, any state that has a high Native American population and has a high alcoholism rate is going to have a very high suicide rate. And also those areas do not have, there's great distances, so to get support for mental health, and there's long waiting lists. So there's also, you know, lack of providers.
And that would lead to a long conversation about where we are with mental health services in this country. Derek Booth, and that will follow with Katie.
Yeah, one of the conversations I just had today with one of the professionals in the social learning department in Peoria Public Schools is the behaviors look different. In the urban population, when you deal with those populations of poverty, when we see students feeling hopelessness, it may not be suicidal, it may not come out as suicidal conversations, but you see hopelessness behaviors, you see suicidal behaviors, you see behaviors that no matter what kind of conversations you have, that your behaviors are either going to lead to death or prison. They magnify those behaviors. Those suicidal behaviors looks different. And when they go on a path of, like I said, maybe gangs or street behavior or really high risk of behaviors, knowing that they're at risk of either death, like I said, or prison. So that's one of the things we're seeing in a lot of the minority populations when they have that feeling of hopelessness.
Katie.
Yeah, thank you. Excellent points made tonight. I just want to note that the propensity toward firearm ownership is greater in rural communities, often for good reasons. People own firearms for self-protection or hunting, or maybe it's been an heirloom that's been handed down. One of the evidence-based programs listed in the Suicide Prevention Resource Center's evidence-based practice website list is reducing access to lethal means, particularly in emergency rooms. So if there's been an attempt, the staff learns to, hey, let me make sure that the family knows that we need to discuss any access to lethal means. If so, we need to make sure that that access has been limited, that there's been an open communication about the need for ensuring that, we know when the timing's right for you to have access to firearms again. That's particularly difficult for law enforcement or others who may have firearms as a part of their day-to-day jobs. Also, we haven't talked at all about veterans. I think it's important to note that the National Suicide Prevention Lifeline is partnering and has partnered for many years with the Veterans Affairs. And so anybody, whether they're military status or family of military or veteran status or not at all, can call that hotline and get expert support. And the more we come together and really wrap our arms around one another, former City Councilman James Polk said at a stigma reduction event we had back in 2005, after our community grappled with this in a very public way, he said, we need to wrap our arms around the people who are struggling. And I've always remembered that as that's just really quintessentially what we need to be doing to help people, one another and ourselves.
We'll get to you just a moment, but I want to remind everybody that we're now in our second hour of a special At Issue town hall focusing on suicide and mental health. We thank you for joining us. We'll be here for another hour. You can participate by joining us socially at, sounds like a party, when I say that, through social media, let me say it that way. Hashtag WTVPAI. And before we get to our other comments, Jamie, we'll go to you next, but I wanted to add, in my research, you talked about gun ownership. Listen to these states. The highest suicide rates, 2016, were Wyoming, Alaska, Montana, New Mexico, Utah, Colorado, Idaho, Nevada, Oregon, Oklahoma. Think about that group of 10. The lowest suicide rates, District of Columbia, New Jersey, New York, Massachusetts, Rhode Island, Maryland, Illinois, Connecticut, California, and Georgia. There's a distinct difference to your point.
Right, and access to psychiatric services is much greater in urban zones. So particularly when we look at Illinois, we have Cook County, which completely skews the data. So if you talk about Illinois, you really have to talk about it Cook County and then the rest of the state. And that we recognize that access to psychiatric services is woefully inadequate, but there's solutions growing. More and more psychologists now are going to be able to prescribe in our state. And so working together, all of us, I'm really excited to hear about the interventions and the collaborations that are happening, and that's what we need to keep doing.
Jamie Harwood, coroner for Peoria County.
Yeah, I just wanted to speak to the demographic of where we sit in Peoria County with our suicide rates, and mostly to her point, when I look at our bell curve of where the most of our suicides are, they are in our 40 to 60-year-old veterans. We have some outliers here, and when I heard other people talk about elderly, we have a handful of elderly, and we have a small handful of our youth who have taken their lives by suicide. But the greatest portion in our bell curve in Peoria County is our not Vietnam, but our veterans altogether in that 40 to 60-year-old age group.
Dr. Boudreau.
I was just going to add a couple of things in terms of risk reduction, because that's why the elements of prevention of suicide is to make means more out of the way and so forth. So if someone owns a firearm, to have that locked up securely somewhere is helpful. The Bob Michael Center makes available trigger locks if somebody needs a lock to put on a firearm. And any number of those things. The #1 suicide site, I believe, in the world is the Golden Gate Bridge. In the last couple of years, they've put in suicide prevention barriers. If you jump off the bridge now, you will get hurt pretty good, but you are much less likely to die. So it's useful to go ahead and survey the environment in which you are, whether it's a home environment, a school environment, or whatever, and have an eye towards where are the tall places, where are the railroad tracks, where are the other points of risk.
And you wanted to add?
I have the privilege every day to work kind of on the front lines of behavioral health within our community, and have the honor to lead an amazing team at Methodist, Unity Point Health Methodist, in the emergency room within our behavioral health intake center. And our awesome little group of people do a couple hundred behavioral health crisis evaluations a day, or I'm sorry, a month. And one of the things that we have to do as a team and as a service line that I just wanted to echo is really the concept of individualized care. When my staff or we as practitioners meet with our patients, we meet the patient where they're at. You know, if they're a veteran, if they're, you know, an aging senior that's just retired, if they're, you know, a young teenage girl that just lost her prom date due to social media, you know, whatever is going on. We really meet the patient where they're at. And the next step as to where we need to go when that patient presents with anxiety or depression, suicidal thoughts, is what is the next best step for that patient? What does that individualized plan look like? What does the discharge plan look like? What does the counseling plan look like? Because it is different for every person. Even though many may share the same diagnosis, the treatment is different for everybody. And that's really where, when we encourage people, you know, get them to the professionals, use the phone numbers, use the resources, because we incorporate you in a team. You know, you are part of that person's recovery team. And that's what we drive. You know, the patient is, the professionals are, the family members are, the schools are, the VA, I mean, all the different community providers. And through the intake center at Methodist, we do have partnerships. We have grown in the last year with working with the VA now, directly meeting with them monthly to help provide that service to veterans when they come in, and help break down some of that stigma. We work with other different community agencies, you know, OSF, Human Service Center, and doing community care plans to try to target people who are, for whatever reason, missing appointments, and try to get them more invested in their own recovery. And so I just really wanted to stress that, you know, everything we're doing is amazing, and that, you know, success can be had if we basically all continue to, you know, to work together and work for that individualized goal.
I think one of the things that's helped in recent years is there are certain fundraising events that have raised the awareness. Whitney's Walk is one of those. I believe that comes under the auspices of the Holtz Center. Holly Bill is here. She is the assistant manager at Holtz Center for Healthy Living.
Yeah, so we have Whitney's Walk every single July, the last Saturday in July, and that goes to raise funds so that we can do our Youth Mental Health Matters programs. It's similar to the ones that Colleen was talking about. We do something similar where we go into the schools. A lot of them are the Peoria public schools that we go to. We teach about youth mental health in various different ways. We partner with Center for Prevention of Abuse to discuss bullying as well. And afterwards, they are able to reach out to a counselor. A lot of the times when we go into the schools, the students think that the counselors are there just to guide them into college. And we know that that's not always the case. There are some counselors who do specialize in that, but there are also children who don't want to go to college. And so we guide them to either their school counselors or the Office of Social and Emotional Learning with Derek, and make sure that they can get connected. So every year we connect hundreds of students to make sure that they can get to counselors either throughout the community or within their schools, whatever is easier. Or Kay will sometimes see some of the students if there is a lack of resources. But it's pretty easy to get them connected, and it's pretty amazing too how quickly they are to reach out to myself when I talk to them. They will reach out so fast and say, hey, I have that going on. And I'm sure that the rest of you being, you know, okay with mental health, get that too. So we're okay talking about it, so we just have to get other people talking about it. And I heard Katie say earlier, I was happy, but then I had signs of depression. So that can be really confusing too to somebody who is a teenager. somebody who has a lot of hormones changing in their bodies. We deal with that a lot within the schools. And so they are really oftentimes very confused about what's going on. They don't want to admit that they have that feeling of happy yet depressed. What does that look like? We maybe show a PowerPoint that says depression looks like this, but maybe they don't look like that or they don't feel like that. It's something that they can't even explain. So we show these pictures that are actually pretty cool. They were designed by students, and they show what does depression and anxiety really feel like. And they really resonate with the students. One of them, for example, is a child walking through mud. So, and we ask, what is this? And they say, oh, I felt like that before. And we get them talking about their feelings. One of them is somebody drowning. One of them is somebody on fire. One of them is a boot stepping on their chest. And so everybody feels these different feelings because our brains are all so different. And so we try to normalize that by saying we are human. Like our brains are, you know, we have chemicals in our bodies. Those change. They're changing right now. So you have to recognize that. So I guess sitting here as a parent as well and listening to all of these professionals as I'm thinking, okay, what else can I do? I mean, I feel like I know a lot, but what else can I do for my own children is talk about feelings from a young age and just start that conversation early. And if they say something like, hey, this happened at school, instead of saying, oh, you know, get over it, just say, well, how did that make you feel? You know, try to introduce the empathy. And so ask how the other people around felt. Just talk about feelings. And then when they get to that difficult age and their hormones are changing, they will be a lot more likely to reach out to you to say, that really hurt, or I really feel like for some reason a boot is on my chest all the time. They might not know that that's depression or anxiety. And so we're just trying to kind of get that information out there so that they can recognize something's not right, and that's okay. It's okay to not be okay. And so we try to teach that to them, to just recognize what's going on, because it might not be what's on the PowerPoint. You know?
Some time ago, we started talking about risk factors for suicidal ideation, and the first one was genetic, and we talked about your family, and you didn't realize it at the time, but you looked back, and there was a genetic connection. Another one is physical, and that's at abnormally low levels of serotonin and dopamine, and that seems to be very common. But how do you recognize that there's a low level of a brain? You know, serotonin in the brain. I mean, that's not something that we easily recognize. I know does anyone deal with that at all?
I saw a cartoon one time, and it was just, well, not a cartoon, but it was one of those teaching moments where you have this round face with not a smile, and it says no serotonin, no happiness. And so it was basically taking away from the whole judging of something's wrong with you, you're not thinking this right, if you would only do this. But it's a basic reality. If we don't have those dopamine and serotonins working right, we just don't feel happy.
And then another category of common risk factors is environmental. Repeated negative life events and experience of constant levels of major stress. And we were talking about college students earlier, and it's exam week. And I always thought exam week was one of the dumbest things colleges could do. I know that Dr. Boudreau is sitting there from Illinois State University. He's going, really, H, you said that? But it's all concentrated into 4 or 5 days. And I just felt pressure and pressure and pressure back then. And so, environmental issues. Yes, Dr. Sierra.
I wanted to make reference. There was a really good study, which I love, done in 1995, if I'm not mistaken, from 95 through 98, between the CDC and Kaiser Permanente in California, and came up with a very good research name ACEs, which stands for Adverse Childhood Events, and essentially it's really identifying out of 11 adverse childhood events and how that leads to not only mental illness but also chronic physical illnesses as patients kind of like grow in age. And it could be anything as, parental neglect, physical abuse, early exposure to substance abuse, So there's a lot of things that we see commonly, and I could just go and spend a lot of time naming all the others, but what I said is that it's the reality of most of the children that we see, right? And it's important to really identify those adverse events that could pose a risk not only for mental illness, depression, anxiety, and other physical illness as we grow older. And then the second point that I wanted to mention, because we're focusing on suicide, and I think it's really relevant, and it's that there are other means of self-injury, right? And that suicide is a very lethal way of injury, but there's lots of, there's a very common way that we see it commonly, and I see it all the time in children, and it happens also in adolescents and adults, which is a non-lethal way of injury, whether it is cutting, burning, erasing, and there's a lot of ways of self-harm which communicates distress, right? That self-injury that is non-lethal, like cutting superficially or scratching, doesn't necessarily mean that you are going to die, but it's communicating a form of distress. And I see commonly in the children that I see at the clinic, that I see at the hospital, that come at the urge of, I cut myself, my mom saw it, or mom saw me putting apart a razor blade. So it's important to really be aware of this and look at your kids when they're at school, pay attention to your children. And when they're at home, right? Some risk factors is, it could be 90 degrees outside and you have a long shirt and a hoodie covering yourself. That doesn't seem right? So that should raise curiosity. And I think that's something that I wanted to mention. Let's be curious about what are you doing? You are 10, 12, 13, 15, so be aware and be curious. Talk to your kids. Communicate with them.
I'm going to give two phone numbers for those of you that would like to jot down phone numbers. These are national phone numbers. The first one I'm going to give you is the Trevor Lifeline. Trevor Lifeline is for the LGBTQ community. That is lesbians, gays, transgender, and by the way, the Q doesn't stand for queer. It stands for questioning. Those who are questioning their lives, their position in life, and especially for young people. The Trevor Lifeline is for adolescents. It's 1-866-488-7386. That's 1-866-488-7386. And the other one is the Suicide Prevention Lifeline. This is a national number. Suicide Prevention Lifeline is 1-800-273-TALK. 1-800-273-TALK. And we've been talking about talking, communicating. I think that's been the underlying theme here. Katie.
Another wonderful resource is actually on the last Thursday of the month in Illinois, we have a recovery and empowerment call. So more talk from people who have lived experience. More and more in the field, we're listening to the voices of people, not only family members who have had loved ones who died by suicide, but also people who have survived suicide attempts, and talk about how we work together to support one another's wellness. NAMI, I know has been mentioned tonight, but the National Alliance on Mental Illness just cannot underscore that enough, the importance of the recovery and empowerment calls monthly in Illinois and run by the Illinois Division of Mental Health, Recovery Services Development Group. NAMI groups in our area, we have NAMI groups twice a month on Thursday nights, I think still hosted through Unity Point Health Methodist. And also there's a Survivors of Suicide support group that Unity Point Proctor hosts on a monthly basis. The family that has been co-facilitating that, Reverend Nimo Hendricks and his wife Pat, have done this since the mid-'80s. And really we need to help support that initiative to continue to reach out to survivors of suicide.
Katie mentioned NAMI, National Alliance on Mental Health, on Mental Illness rather. Tasha and Colleen, did you want to address that a little bit more in detail as to what kind of services you provide?
Actually, in Livingston, McLean County, NAMI has a support group at Chestnut Health Systems on Martin Luther King Drive, which is at 1003 Martin Luther King Drive. And we have it twice a week for those who have mental illness. It's the Connections group. We have it on Tuesdays at 4:30 and on Saturdays at 10. And we also have the family support group at 10 as well on Saturdays. And that's in Bloomington.
And if you go to the WTVP website, that's www.wtvp.org, we have on the website the websites of some of these organizations and also some national contacts, so that there's a lot of research and a lot of reference material that you can access there at wtvp.org. I want to go ahead, Doctor.
I was just going to add, in terms of the situational risk factors, particularly you want to be looking for losses. That could be losses of a grade, that could be losses of a lover, that could be loss of health, a job, whatever. So frequently there's a loss situation which may kind of trigger the suicidal ideation. It isn't solely responsible for it chiefly, but it's just the factor that's more of a triggering factor.
I would agree with that, and I think that that links back to those adverse childhood experiences. And I think that reframing our discussion of mental illness as what has happened to you can be a great way to reduce stigma, that it's not what's wrong with you, it's what has happened to you that's making you feel this way, that it's not just something that happens in a vacuum, that often there are things going on in people's life that make them feel like life is never going to get better. And I think that that's a wonderful place for people with lived experience to step in and provide that example of, yes, sometimes it's going to hurt very much to be alive in this world, but it's also going to be able to bring you a lot of joy and to show them that it is possible to live in recovery.
Samuel Sears.
This gets into a lot of resiliency and coping, and every individual has different levels of how resilient they are to trauma, how much they can cope. Often when people have had a lot of trauma in early ages, there's diminished resiliency and diminished coping developed over time. And so working on helping people see that there are ways of developing those, linking with people that have been in their position and have made it through, can be very helpful in that process, and making those connections so that they see there is something further that can be much better than what they have right now.
Samuel is with OSF Healthcare, and either order, I don't care. Both hands went up at the same time.
I just wanted to mention that I think another place to look is in primary care. Dr. Sierra mentioned the connection with physical illness or medical illness, and so I think our primary care providers are in a place to be able to identify those patients that are coming in, either because a chronic medical illness leads to depression, for example, or a mental illness manifests itself in a physical manner. And so, I think pairing behavioral health clinicians with primary care so that there can be early identification when it manifests itself in a physical manner, I think is incredibly important.
And along with that, of the long-term care. And I know a lot of times it's thinking get patients in and get patients out just because it's more efficient. But it's not efficient in the long run because they're constantly having to then return in a crisis. But if people that you know that have had traumas through their life and that this is going to trigger when they go off to college or they get married or they have a child, that through these crises that they need a primary care mental health person. Just like, and I'll tell my patients that when you're sick, you go for a cold, you go back and see your doctor. Anything happens, you go back to see your doctor. That I tell them, look at me that way. Even though things are going well now, a little upset or whatever goes on, just come back and touch in. You can come at any time. But kind of developing that mentality that mental health isn't a one-time thing. Oh, I had a bout of depression. Now it's over, I'm fine. Or she was suicidal as a teenager, and now she's fine. But thinking of it more as a lifestyle of how am I going to deal with this throughout my life. And I'll tell people that these are different times when your memories from the past could be triggered. You may have difficulties. At that time, you might want to seek help.
Jamie Harwood is just departing. I was going to ask him one final question, but if you could come back real quickly, Jamie, and then we'll let you go. We've been talking about people who have suicidal tendencies and recognizing those issues in advance. I'd like to turn the conversation to suicide survivors. You're a suicide survivor. Your brother died by suicide. And so to both you and to Jamie, is there a survivor's guilt? And to Jamie, is there an issue when you notify family members? Do they start to say, I could have done something? Cindy first.
Yes, I think that's inevitable. It certainly was in my family. While I talked to Tim very frequently, and I was noticing things, being different. I did ask him, but it's definitely, gosh, I could have done more, and yeah. So it's inevitable, and I know my other siblings, especially my older brother who lives up in the Chicago area, and he was aware too, and so it's the guilt to the extent of, what could we have asked something in a different way, or pursued it a little more with him.
So how did you support each other? Did you seek professional help? How did you cope with that?
We really relied on one another. I probably should have personally done a better job of going to the Survivors of Suicide group. I always felt like my pain was different than anyone else's, and even though I was going, I would be going to that, they couldn't possibly understand my pain, and I know that's not reality, and so I would recommend that to anyone. But we really relied. We were lucky that we had such a large family. We really relied a lot on one another.
Let's turn to Jamie Harwood, the Peoria County Coroner. The difficulties you described earlier, I don't know how long you stay with family members when you're telling them of the death of a family member by suicide, but do they start to talk about these kinds of things, survivor's guilt and those kinds of issues, and how do you cope with that?
I stay with families until they kick me out. As long as I can be there with them through that moment, I stay there. First of all, I've had a mix. Some of my families that I've sat with in their homes are mystified. They had no idea that it was coming. And even when they track back to try to think of some warning signs, they're oblivious to anything. I've had other families, however, look back and say, gosh, you know what, I noticed this, this, and this, and I should have done something. And it's usually in that moment where I try to tell them, regardless, it was that person's choice. Me as a survivor really had nothing to do with that decision of that other person, and hopefully in some manner that takes away some of the guilt that they might feel. And I don't even know if that's true, but I try to encourage them to believe that they didn't have anything to do with that other person's decision. Okay. And it's tough, because they feel responsible.
Thank you for staying an extra couple of minutes. We appreciate
Absolutely.
it. And did I see a hand over here someplace? Maybe I did not. Oh, right here, okay.
I think that's really crucial to talk about, is that survivor's guilt, because I think it is so hard, whether or not the person died by suicide, but even to know that someone you love has attempted suicide, has felt so alone that they would do such a thing. And one of the things that we always tell our kids when we talk to them about suicide prevention is that suicide is not preventable every single time, and that it is very complicated, and that if they have ever lost someone to suicide, it's important that they know that that's not their fault, because I do think that that's where we go. We go to, this is my fault, what should I have done? And so we always let them know that they can do a lot to help people. They can save somebody's life, but that it is never their responsibility to save someone else. That their primary responsibility is to take care of themselves and their own mental health. And if they can do more, then that's wonderful. But it is never their fault if someone makes that choice.
I think that's an important issue, because shame and depression and things like that, anger sometimes comes out, and then they don't take care of themselves.
Yes, very much so.
Deborah.
And we live in a society today where we can get an answer for everything. You can Google in a couple of seconds and you know whatever you need to know. The unknown of, why did this person do this? Could I have done something different? A lot of times I'll just sit with people and spend time with them talking about, this is going to be something now that you're going to be living with. Getting used to not having the answer, and maybe never having the answer. And what is that like? Because it's just so natural for us to find an answer, and if we can't find one, then okay, it must have been my fault. And we almost feel, and I say, do you really going to feel a sense of relief if you can figure out why this person did this? Because they're being taunted by their brain trying to figure it out. So helping them to just be in that moment and knowing that this is an experience that maybe you've never had before, or finding out if they have had it before. But it's going to you will get used to it. But it's not your fault, but it's living with that emptiness of not knowing.
Do survivors turn to the same professionals? Rob, do you deal with that?
Survivors of suicide? They certainly can. Yeah, absolutely. Because as we've pointed out there's a lot of different symptoms that go along with that. The shame, the guilt. Actually, one of the calling cards of depression is inappropriate guilt. That sometimes a person will look to that and say, how could I have done more? I must have missed something. What was going on? When in reality, no, there wasn't. But they're so overcome in that guilt that increases their depression, that keeps them up at night, that causes a trigger of multiple depression symptoms. So absolutely, it can be a very impactful occurrence that, yeah, they absolutely should seek mental health treatment in that case.
Something I was going to add that if you know someone who's died by suicide, that puts you automatically at a higher risk for suicide yourself. So that's it. So that's something to be aware of and to seek out help.
Mike Kennedy is President and CEO of Human Service Center in Peoria.
I think one of the things as you asked about people who are survivors of suicide, many of the professionals sitting here are in that category too. If you've ever had a client who's committed suicide, you go through the same process. And people think, oh, well, you guys are all psychologically stable so you can handle anything. Most professionals have a sense of responsibility with an individual who's suicidal. And, a person that commits suicide, fortunately, you're surrounded by other professionals, and most systems are set up that if you have one of your coworkers who has had a client who's committed suicide, there's usually a protocol. They come together, and you become part of the healing process yourself.
Is it difficult for a survivor to grieve publicly? Is that something you had to do? I mean, you're an outgoing person. Come on, Cindy. But I mean, seriously, I'm not going to talk about it. I'm embarrassed. There's that stigma. Tim died by suicide, and I just can't talk to anybody else about it except my siblings.
No, I did not feel that way. As a matter of fact, I think because it was Tim made me want to talk about it more because I felt it was so important. But, we did have, people who, were fairly insensitive and, would say things, about our faith and what suicide means, for our faith. And that was difficult. And, those kind of things, I can see why people feel, embarrassed or, ashamed. But we had wonderful clergy at our parish who assured us that, we had nothing to worry about, in that regard. And so I just never felt ashamed about it.
Derek Booth is the director of the Social Emotional Program at District 150. No, I don't call it that anymore. See, there's that habit, District 150. Peoria Public Schools. Sorry, Dr. Karat. But let's expand that survivor discussion. Classmates. If someone in a class dies by suicide, obviously the class is going to know that. Is there a process that Peoria Public Schools has to help those kids?
Yeah, not only suicide, but any death that impacts students. Our typical response is the grief counseling, the immediate grief counseling. Some of the discussions that I began having the last 2 years with staff and support staff is the need for that continued grief counseling. We're very good about putting supports in place, during that initial week of a loss of a classmate. But a lot of times, just understand anyone that's dealt with loss or dealt with that type of loss, during that first week, during that first year, you're really numb. That true healing, a lot of times cannot take place until a year later. So remembering those students that were impacted by the loss of a loved one, and even the next school year, following up to see what type of grief supports are needed. And I think it's very important, and because grief is not just that week, just not that week or just that month for those students, but just to continually to make sure that the students are on our radar that are impacted by loss, whether it's by a classmate, loss of a family member, and those supports continue throughout their educational career.
Rob.
One other point I wanted to make too, you gave a few hotline numbers, which are fantastic if you're in the middle of having those suicidal thoughts. There are also lines available to where even if you don't feel that you are suffering from suicidal thoughts yourself, but you are struggling with depression, or somebody that you know is struggling with mental illness, that you can call the Warm Line is through Illinois. Path Outreach in Bloomington Normal is a fantastic emotional support hotline that I believe also still answers for the National Suicide. So, and I used to volunteer there, and those are wonderful resources, not just for information, but also just for that emotional support, that even though I might not be contemplating suicide, I'm still beside myself, I'm still overwhelmed, I need somebody to talk to as well. So I just wanted to plug those services because those are wonderful services.
And what we'll do in the next 24 or 48 hours, we'll get some of those phone numbers on the WTVP.org website, and you can access those. By the way, PATH wanted to be here tonight. They're in Bloomington Normal. PATH wanted to be here, but they had all-day training today, so they could not participate.
I just wanted to tag on to the resources locally. 211 United Way's 211 is a great resource.
Heart of Illinois United Way, that's operated out of the AMT facility. 211 is a lot of help at 211.
Yes, I have a question for those that work in the schools. If a child is being bullied, I know that of course, there's services to deal with that. But when they're actually being bullied in the way of being told to kill themselves, is that more of a red alert? I mean, is there any service intervention that's different? Because it's just my experience in working with the children that I almost feel like when a group of kids tells another kid that, they're pulling a trigger. I mean, that is the heavy experience to experience if it's a whole group of children taunting a child. And I've had that happen with different children. And I'm just wondering if the schools react any differently.
Can anybody handle that?
Well, Partner Community College has what we call a behavioral intervention team. So when there's ever a threat or something going on in the college, we meet. It's a 4-person team, and counseling services is involved. And we look at, is it a sending threat? We do investigations across the college and make sure we get the proper information and who's involved, and talk with the individual themselves, and then try to precipitate any event.
Thank you, Faye. Derek, you were going to add.
Yeah, just to add on that, all of our, any accusations of bullying is definitely fully investigated, and support's provided to the victim, but also for the offender that may be initiating. That's not only conversations with the offender and the family, but also in those severe situations of, there's legal measures that take place for issues such as bullying that we fully make the offender aware of and the families aware of, and that this is a major issue that we're dealing with.
Katie? Katie first.
Well, Mr. Booth's leadership within our school district with the social emotional learning, this really does start with the very young children. I mean, my kids are in elementary. I've got 4 kids, so they're in all stages. But my youngest are learning about a book called Wonder. We read it, and they're reading in their classroom about a child with physical abnormalities, and about how the students are taught through this book and through leading and experiential learning exercises in the classroom about how we, again, wrap our arms around people and avoid ostracizing. So we really have to plant those seeds at those very youngest ages, preschool, and that's what the social emotional learning is doing. It is working. I have to say, my child gave me a litany of a description about the Center for Prevention of Abuse programming that's done to help children. I mean, she's 8, and she spoke about it very eloquently at length about how if a child is being abused or neglected, back to that ACEs study, how they should tell an adult. And I'm so impressed with how Peoria Public Schools are, I said it right, and other schools in our community are handling those issues. It's a statewide standards.
Colleen.
I think it's important to recognize when we talk about bullying in schools that in addition to services being needed for the person who is being bullied, sometimes the bully themselves needs arms wrapped around them, that a lot of young people respond to stress or distress or feelings of insecurity by lashing out, and that sometimes they are the ones that most need us to pull them in and to tell them that their life has meaning and that it doesn't have to be this way.
I wanted to share some numbers with the audience, the viewing audience. These are all suicides The number of deaths nationally hovers every year around 44,000. That's more than die of homicide. That's more than die in automobile accidents. 44,000 suicides a year in this country. The deaths per 100,000 of population, 13.4. And if you look back over time, that number is rising. The cause of death, the rank for the cause of death, suicide is the 10th across all suicides, the 10th most common way of dying. There are 121 suicides a day in this country. 50% of the suicides in this country are by firearm. We were talking about the states earlier. And 27%, about a quarter of the suicides, are by suffocation. And when you say suffocation, you're going, really? Well, that includes hanging. And then 16% of suicides are through poison, medicine, things of that nature. Amy.
Yeah, I just wanted to make a point that I'm sure that members of the viewing audience are finding those statistics to be pretty startling. But the reality is that that doesn't capture all the suicides. Mm-hmm. Because, I mean, if you think about it, a single car accident or a single, car with a single driver, for example, runs into, a pylon or something like that, may be considered an accident unless there's definitive proof that it's suicide. And so the reality is that even though you've got the current stats, you do, it's just that the rates are actually much higher than that. It's just that if there's not definitive proof that someone's completed suicide, it's not always ruled as suicide.
Well, then we have to add on top of that suicide attempts. And those numbers are unbelievable. That the number of people who have attempted suicide in this country are just really not tolerable. And we need to address the mental health issue because approximately 90% of suicides and suicide attempts have something to do with a mental health issue. And if we don't start addressing mental health issues, we're not going to be able to tackle the suicide and suicide attempt issues either. I saw someone shaking their head, and I don't know if it was Kay, somebody back in back. No, okay. No, she's shaking. Now she's going like this. Sorry. Samuel.
To your point on the difference between attempt rates and completions, actually the poisoning rate you gave is actually the most common attempt you'll actually find. People most frequently overdose. However, it's less likely to be successful. And so that's something that we have to be very conscientious and aware of also, that it is a commonly attempted method using over-the-counters, things found around the house, found in other people's houses even. And so being very careful with medications, making sure that we don't leave very lethal means available to people or very close to lethal means available to people is also a very important part of prevention as well.
Is the point that they're using some sort of poison, a medicine, of something like that, is that they really don't want to die, they're asking for help, and this is their way of reaching out?
Some people have that ambivalence. Some people believe that it'll be much easier to die from the poisoning than they actually are. Can't even tell you the number of times I've seen person took the overdose, went to sleep, woke up the next morning sick, feeling terrible, and then someone found them or they called for help just because of how uncomfortable they were from that overdose, and they lived through it. But that then becomes a point of we gotta work real hard for that person to make sure that we don't count on good luck happening again in the future to have a chance to help them.
Colleen and Tasha.
Speaking of the danger of abusing prescription drugs, I just want to let the audience know that tomorrow is actually Prescription Drug Take-Back Day. And so many of the local police stations are participating, and that if you have extra medicine in your house, it's a great idea tomorrow to bring it to the police station so that it doesn't fall into the hands of someone who might use it to harm themselves.
And many of the police stations, Chillicothe, Peoria Heights, Bloomington, Peoria, and these police stations, the Peoria County Sheriff's Office and the Peoria Police Department have a standard, it's like a mailbox. You just go in and put your medicines in there, expired medicines, medicines that you're no longer in need of. Tasha.
Thinking about how important it is that prescription drugs are the most common source of overdose, source of suicide. I think it's important that we talk about how important that support systems are when it comes to keeping people stable with mental health, because your support system in your mental health is what keeps you in recovery. We've talked about recovery a couple times in mental health. My support system is my husband, and he's part of what keeps me in recovery with my bipolar. And staying in recovery is the most important thing to me with my mental health. And part of what keeps me in recovery is the fact that he keeps my medication locked up. Anything that could cause me to overdose is locked up into a safe. And that is one of the things that keeps me in recovery. Every morning he gets into that safe and he takes out the medications for me and he lays them out because he is stable. He doesn't have a mental illness. So in order for me to stay in recovery, he is my support system. He gets into the safe and he puts out any medications that would be able for me to overdose in. So people who have a mental illness and they need those support systems. And so sometimes it takes people who are stable for people who have a mental illness to stay in recovery.
Deborah.
Well, I was going to add that earlier I was saying that sometimes people just have to learn to live with the unknown. But when we do have a lot of those factors that we know, that someone had a lot of trauma, somebody was overwhelmed, they didn't have the coping capacity, that there were all these other factors going on, it also does help families to know that this can happen. You know, that this is often the result of all of these things. So it does in that way sometimes help them to realize that they were mentally ill and this is something that the brain can do. I'll often tell families that it was an impulsive act, that it doesn't mean necessarily that they wanted to kill themselves. I mean, I've had kids that, you know, have attempted or even adults and then they've survived and they've said, oh my gosh, I can't believe that. I had one that actually did die, but on the deathbed was saying, oh my gosh, I want to live. I can't believe I did that. So it's often like they'll say, well, did they really want to die? You know, with it's also, it can be a panic of that moment. And it doesn't mean really that they wanted to die. It's just at that moment, they were impulsive, things were there, or they were going through a bad time, and that became a feeling of something to do.
Samuel.
I just wanted to echo how important connectiveness is to recovery, not just in pure mental health, but also in substance dependence recovery as well. Connectedness is the pillar of recovery for people ongoing in substance dependence treatment. It's the cornerstone of how the 12-step groups work. It's working with other people that understand your problem, being connected, being responsible to one another. Works the same in mental health groups, works the same in families that are supporting one another. This is how people have long-lasting wellness, is to have that sense of connectedness to something more than just themselves.
Dr. Boudreau.
Just a couple of quick points, because we were talking about attempts earlier. I think sometimes people tend to de-emphasize attempts, and oftentimes the comment is, oh, they were just seeking attention. Well, as every baby knows, we all need attention, okay? So sometimes it's an issue of, you know, it's a good reminder for the audience to take all suicidal threats seriously, and don't believe in that crying of wolf.
And let's go back to that QPR process and remind the viewing audience of that.
Right, so QPR is what's called a gatekeeper training program that basically allows people who are in contact at Illinois State with our students to be more likely to be able to catch problematic behavior and be able to intervene by questioning the person about whether they're suicidal, persuading them to get assistance, and then referring them to appropriate assistance.
We mentioned earlier in the program that too often we, as friends or acquaintances, we just back away. We don't question. I don't want to get into that person's business. Are you kidding me? I'm not touching that. We really should step forward and question and not feel embarrassed if we ask that question and they say, I'm okay. Even if they say they're okay, you should question.
Exactly. Some people are concerned about planting the notion of suicide. If that were true, this broadcast would be pointless because we've been talking about it for 2 hours. So the notion of talking about suicide will not engender suicide in someone who hasn't thought about it. So being able to ask the question, and that's part of the training that we do, is to talk about the wrong ways of asking the question, like, You're not going to do something crazy, are you? And some of the right ways to ask it. Are you in such pain that maybe you've thought of harming yourself in some way? Have you thought of taking your life? And we have them practice that out loud, so they've said it at least once to some other human being in the training setting.
Rob Walter.
One of the going back to the normalizing of these types of feelings and normalizing these types of conversations, I find the hardest hurdle to get over with many clients is sort of this notion that if you give human beings like a house and family and money, that they're just naturally going to stay happy, that that's just the equilibrium state of human beings. But in reality, our emotions fluctuate all the time. It's a never-ending slide of up and downs. So I think that's continuing to educate the public, continuing to educate families that just because somebody is feeling this way does not make them abnormal. In fact, it makes them quite typical. That this is a very natural way to feel in a lot of ways. And it should be approached as such, and therefore asking those types of questions hopefully become as second nature as to, do you think that you're having some kind of medical problem? Do you need to go see a doctor? Very similar to, do you feel as though you might hurt yourself? Do you feel as though you might be suicidal? Do you feel like, and asking those types of questions, putting those sort of in the same category together.
And don't stop at that first question.
No, follow-ups.
Samuel.
I'd also like to put out there that really understanding there is no wrong way to feel. There are only wrong ways to act in response to those feelings. And so any way that a person can feel is totally normal for them. It's what we do in response to those feelings, how we deal with them, how we seek help or don't seek help, what we do to get those feelings out that can be adaptive, maladaptive, harmful, helpful. And that's really an important message for people to understand. There is no wrong way to feel inside, though.
And Deborah?
Well, I was just going to add that, we're all talking about everybody else, but we really need to talk about us. Absolutely. Because we're all, people on this planet struggling and going through our ups and downs. So it's really our own mental health. And when you're talking about approaching someone and talking about it, that's a perfect way to start it. I get really stressed out, and this is how I handle it. Or this is how I manage stress in my world. How do you manage it? Sometimes I feel like this. How do you feel? Especially if it's a family member. I'm not talking about in a therapeutic setting, but... yeah, and even sometimes that way, I'll start out that way, but sometimes I get stressed. Well, how do you handle it?
Let's talk about that, because I get stressed, maybe not on a daily basis, but there's stress in my life. I get anxious. I don't know if I suffer from anxiety or not, but I get anxious. Right before a live show like this, I get anxious. That's normal, I think. I hope that's normal. But when we know that, I mean, sometimes you feel a pressure in your chest or whatever it may be. Are there methods that we ourselves can use when we feel that we sense this feeling? What should we do? I mean, and don't tell me go lie down, because I'm just going to do a live show. So, but are there suggestions as to what you do?
You have a lot of mental health professionals
here. Faye, did you want to address the issue?
There are methods and techniques that you use, like in breathing and stress reduction, progressive relaxation, and mindfulness. And a lot of the schools in the United States are starting to teach mindfulness in school. It addresses the bully issue by engendering compassion and gratitude. So there's a lot of different techniques.
Yes.
I just want to take a second just to talk about the breathing that you mentioned. That's the technique that I often will give my clients is like breathing to help in situations where they're feeling anxious. And inevitably a response that I get is, seriously? Like, you're going to talk to me about breathing? Like, as if breathing is going to help me right now? And there's actually a whole physiological reason why changing the way that we breathe can help us calm down. Kind of like our kind of reptilian brain, like back here in the back of our heads. Like if the lion is coming to eat us, like our body physiologically responds in certain ways. And one of the things that happens is our abdominal muscles will like tighten up. Some people think that's to kind of protect some of those organs that don't have any bones around them. And what that does is it forces us to not use our whole diaphragm to inhale and exhale. So suddenly our breath is just in our chest, our chest will rapidly be rising and falling in that situation of anxiety. You know, like you mentioned, the live show might triggered my anxiety, you know what I'm saying? But the lion's not coming to eat me, right? Like, I'm physically safe, I'm here, everything is okay. So something that you can do is you can be really mindful about your breath. And a way that you can do that is by putting your hands over your belly button like this and making sure that as you're inhaling, your hands are coming out with your inhale and they're falling with your exhale. And just helps us to kind of get our breath like out of our chest and back down into where we're using our diaphragm to open up our lungs as fully as possible, because it's actually physiologically impossible to stay in that panicked mode if you can move your breath back down into your belly. So it's not hokey, like it's real. It really helps.
Amy Roberts is with the Tazwood Center for Wellness. A final comment, or next to final comment, because we always ask Mike Kennedy for a final wrap-up.
I think that the importance of coping skills cannot be overstated for people who live with mental illness and people who don't. One of the things that we give the kids who participate in Ending the Silence is a list of 99 coping skills, which is everything from deep breathing to building a blanket for, you know, fun things, but also things that might help them get into a better frame of mind. And one of the things that I think is important is developing personal mantras, so things that you say to yourself. One that I use every day is one good thing at a time, because I tend to get overwhelmed and then think about all the things that could possibly go wrong. So I have to focus on one good thing at a time. And I think if we keep saying those things to ourselves, we can retrain that voice in our head that says that we're not good enough, or that says give up, and we can train it to say keep going.
Very briefly, Mike Kennedy of Human Service Center, having reflected back on the past 2 hours of conversation, what's the takeaway that we can share with the viewing audience? Well, and we'll give him just a second to...
Oh, God, H.
You knew this was coming, Mike.
I think the biggest thing is there's light at the end of the tunnel here. And the light at the end of the tunnel is here and is all the audience. I don't want to be a pessimist, but I'm not optimistic that there will ever be enough professional resources to meet all the behavioral health needs that's in this community. And so we're finding other ways to help people.
And with that, we thank you all for sharing your expertise, and we thank you for joining us on this special edition of At Issue, looking at suicide and mental health. Go to the WTVP website, WTVP.org, for more information. We'll be adding to that information as the days go on. Thank you for joining us. Have a good evening.